Good afternoon. Thanks for having me today. My name is Dr. Brad Housman. I'm Vice President and Chief Medical Officer here at Baptist Health Paducah. That's a role that I've had the pleasure of holding for the last 8 years or so. Prior to me taking on the administrative role here at the hospital, I was a practicing OBGYN physician here in the community. So this is a interesting departure from my previous clinical background in delivering babies, but a very timely topic for us to talk about with regards to COVID and some of the things going on in our community. So to the extent that we can, as mentioned, I'm happy to take questions, and we can do some of those as we go through the slides. So if there are things that come up, if I happen to see it in the chat or if somebody brings it to my attention, we can try and address that, and we'll certainly save some time at the end for any questions. So next slide. So a little bit of background about coronavirus. It's a group of viruses in mammals and birds and responsible for things such as respiratory tract infections and even some of the common colds. Even though it really burst onto the scene for us here in the U.S. Back in the December-January timeframe, we've known about coronaviruses since the 60s. And the name coronavirus, as you see there on the slide, is derived from the Latin word corona, which means crown or wreath. So if you look at the picture there to the right, that's an electron micrograph of a coronavirus, and you can see that it's sort of studded around the outside of the virus. And if you were to look at it in cross section, it would appear like a crown. As I mentioned, there are various strains of coronaviruses, and in fact, if we think back over the last decade, some of these we're familiar with or have heard about, things such as SARS, which I believe was in about the 2003-2004 timeframe, and MERS, which was another respiratory virus. Both were out of China and the Middle East, but they were kind of both popped on the scene in the early to mid 2000s, but then thankfully were kind of short-lived, so we never really saw that many outbreaks here. But the name of the one that has really caused all the fuss this year is SARS-CoV-2. So that's the name of the virus, the current virus, and as you see there on the bottom of the slide, COVID-19 is a combination of coronavirus disease 2019. So that's where that name derives from. But the official name of the virus, the strain, is SARS-CoV-2. So next slide. This slide's just kind of funny to me. Maybe I've got a different sense of humor, but someone had sent me this slide, and I remember some of the first talks that I gave. We were really discussing a couple of things that were unique about this, and one of them was, is this really even going to be a big deal? One of the first talks I gave was to the Kiwanis Club, and you'll see a couple references in some of the slides where we talked about, yes, we feel like this is going to be a big deal, and some changes they may need to make in terms of meeting and the like. But for all of us that for all of those of us that had our doubts about if this was going to turn out to be a big deal, I think we can all agree that it is a big deal. It certainly has impacted our life in ways we never quite thought possible. And unfortunately, I feel like it's here to stay for quite some time. So the last point that I'll make down there at the bottom, and it's a little bit of a picky point, but it sometimes helps to keep in the back of your mind as you're seeing things and reading things. SARS-CoV-2, as I mentioned, is the name of the virus. COVID-19 is the disease that comes from that virus. So when you're looking at recommendations about things with regards to COVID-19, the assumption there is that's a person that is suffering from ill effects from the infection of the SARS-CoV-2 virus. So again, it's a little bit of a picky point, but sometimes we mix those things up, and we can jump to wrong conclusions if we're not super careful. So Next slide. The next couple of slides are just some overall views of what's going on in the country and in the world. These were from over the weekend, and they graphically display some of the hotspots within the U.S. Are y'all able to see if I move my mouse? I don't suspect you are, but if you recall, probably the couple of interesting things to note. If you recall, when this first started back in the March-April timeframe, it was centered in the Pacific Northwest and also in the Northeast around New York City and the like. And you can see that those areas really have somewhat settled down, and the current areas of concern are Texas and the Southeast. Specifically, Texas and Florida are getting a lot of the press currently. And then the next slide shows hotspots throughout the world, and it's if we go into the next slide, we'll see that it's principally North and South America where we're seeing a lot of it. So admittedly, some of the lack of demonstration of disease, particularly in Africa and the like, may be due to testing and reporting, but nevertheless, the bulk of where we're seeing COVID outbreaks and COVID hotspots is North and South America. Next slide. So this slide has a lot of information, more particulars on the numbers of what's happening in throughout Kentucky and then the United States and also the world. A couple of highlight points that I'll make. The numbers themselves, I won't dwell on the specifics too much, but it's interesting to note that throughout Kentucky, we've now had cases reported in all of our counties. The other thing that's interesting is I used this slide about a month ago, the 1st of July, for a talk with Kiwanis Club, and I was struck that when I updated this slide the last couple of days, that these numbers had roughly doubled. So when I gave this talk 1st of July, for instance, the Kentucky cases were at about 16,000, and we're at about 2.5 million throughout the U.S. And in a little over 6 weeks, our numbers had nearly doubled. So still certainly seeing a lot of increase in diagnosis and increase in testing and occurrence of COVID-19 throughout the state and throughout the U.S. But hopefully, as the previous slide, the first slide with regards to hotspots in the U.S. demonstrates, we're beginning to see some decline in some of the numbers. Next slide. So this slide is as of 8/15 and really breaks it down throughout the state and shows areas of community spread and breaks it down based on 1 to 10 per 100,000 population, 10 to 25, and so forth. So I would agree with what's being depicted here. Our testing rate at the hospital has been consistent with probably 10 or fewer positives per week. And that's what's shown there with McCracken County being in the yellow. Mayfield and Graves County area have been areas that have had more incidents of cases, and we'll see that in another slide in a moment. But for the most part, Western Kentucky has been pretty consistent. So you'll see a little bit of increased activity down around Fulton area that would be important for us to know for Western Kentucky. Next slide. So a little bit of background about this slide. This one's, again, kind of interesting to me. That as I mentioned, I spoke at Kiwanis, and that was on March 12th. And as of March 12th, we had tested 64 people, 8 positive test results, no deaths in that group. And that's that next point was where I'd suggested to them that they might consider not meeting in person. So Interesting to think about how far we've come as a society when really just not too many months ago, it was a hot topic of debate about whether or not meeting in person was safe and prudent. But I did make that suggestion to them in March. In the months since then, these were numbers for us for Baptist Health as of August 17th. We've now tested nearly 15,000 or over 15,000 patients. Numbers that I tend to review and look at consistently. We break them down into three groups of folks, and it helps me keep an eye and helps keep a gauge on, are we seeing a spike or an increase in the diagnosis of COVID-19? The first group that we look at is pre-procedure asymptomatic patients. So those are patients that, if we recall, early in the disease, there was an executive order put out by the governor where they suggested that we not perform elective surgery. And so we did that for a time. And one of the mandates as we began to resume elective surgery was that we test everybody for COVID prior to surgery. And so that's what this group is. So as of this date, we had tested almost 7,500 patients for surgery and or procedures here in the hospital and had only found 24 positives. So that's a very low number, and that's a good news point to make. That works out to an occurrence rate of about 0.32%. So again, if we wanted to think about this patient population, this is a group of folks that are otherwise healthy. They're not having symptoms. They just need surgery, say, to have a hip fixed or maybe have carpal tunnel surgery. And through that testing process, we find out that they're positive. So very low rate there. Our rates in the ER of symptomatic patients and urgent care of symptomatic patients are 4.8% and 7.2% respectively. And I just threw this number in. It's not accurate now. We've had discharges since then, but currently we had 7 positive inpatients here in the hospital. So if I look back over occurrence rates, breaking it out by week, that's something that we've started doing in the last few weeks as we consider going back to school. Frankly, we're kind of watching our community and seeing if we're noticing an increase in trend and rates. And our positive testing rate has been in the 2 to 3% really since mid-July. So it has not changed in a significant fashion in the last 4 to 5 weeks. So our year-to-date positive testing rate, for the record, is about 1.6%. So in keeping with that prior slide was showing us in the yellow, if you will, which is a community spread of 1 to 10 per 100,000 people, we're doing a good job of limiting spread throughout the community. Next slide. Next slide's an unfortunate one in that it looks at death associated to COVID. And you can see a couple of hot spots there. And it is worth noting that for Western Kentucky, at least early on, you'll note that this is deaths through June 30th, that there had been an increase in number or a higher number than expected in Graves County, but that has since settled off, thankfully. Although they're at a little bit higher rate of community spread than some of the surrounding counties. Next slide. All right, so we're going to transition a little bit away from the virus and the occurrence of it a little bit to talk about some of the hot button issues, if you will. And I think mask in public is something that certainly a lot of folks have opinions and thoughts on. It means a lot of different things to a lot of different people. But this is one of my favorite slides, and it succinctly addresses why masks have importance and where we are today. So the summation of this slide is at the bottom. When I wear a mask in public, which I try and do as consistently and often as I can, I do it out of concern for others, not for concern for myself. So that's really the bottom line. Is I'm doing it to try and protect others. And if you study the numbers on this slide, that's exactly what it shows. So the person in the upper left, they have COVID virus. They may or may not be sick, but they're a carrier of the SARS-CoV-2 virus. If they do not wear a mask, and I am wearing a mask and I'm talking to them and in close proximity, there's up to a 70% probability of transmission despite me wearing a mask. So that's really where it comes down to wearing a mask. The mask that we're talking about, either surgical mask or cloth mask, is to protect others. Because you'll notice in the middle there, that same person with coronavirus that's wearing a mask, if I forgot my mask or didn't have one on, my chance of transmission, of catching it from that person wearing a mask, goes from 70% down to 5%. That's a huge decrease. So again, if you think about the fact, and I haven't highlighted this yet, but it's pretty well documented that a large proportion of people with coronavirus are asymptomatic or very mildly symptomatic. If 80% of the people that have this really don't know that they do, or they're just, they might attribute it to sinuses or headache or an upset stomach, those folks would be that COVID carrier. And if we can have them decrease their chance of passing this along from 70% to 5% simply by wearing a mask, it's worth doing so in all circumstances. The last group of people, they show that if we both wear a mask, the chance of probability of transmission, or the chance of catching it, drops down to almost 1%. So for me, that's really that really sort of settles the whole mask debate. To me, it's not about personal rights or liberties or freedoms or any of those things. If I digress a little bit onto the political side of masking, it's really about me trying to protect other people I come in contact with, whether it's friends or whether it's clerks in a store or folks in a restaurant. If I can be careful with my mask and do that, then I can really try and prevent from transmitting it if I was an asymptomatic carrier. So next thing we'll move on to, we'll talk about vaccines for a moment. So I'll start with no, I don't know the date of when we'll have a vaccine available, but I wanted to back up a step and just talk about when is a vaccine. And what you have here is a list of the different stages or the different things that we have to go through typically to demonstrate that vaccines are both safe and effective. And you've probably heard some of this jargon or lingo in the newspaper reports and in the TV reports, but we talk about vaccine trials in terms of phases: phase 1, phase 2, phase 3, and you can see those listed there. And we'll go to a slide in a moment, or actually we can go on to the next slide. You'll see I pulled this from World Health Organization from over the weekend, that we've got an awful lot of thoughts and plans and vaccines in preclinical trials. But really, if we accelerate to the phase 3 stage, excuse me, which is a large-scale efficacy trial where you're looking at how effective the vaccine is, we really only have 7 vaccines that are in that phase 3 stage, and none in the US that would meet approval. Next slide. So a little bit or a few comments about vaccinations and some important things to consider or to remember. I'm going to go out of order here. But if we think about vaccines and in the normal course of vaccine development, most vaccinations actually take quite a long time to develop. So it's estimated or averaged that most vaccines can take up to 10 to 15 years to develop. So the idea or the notion that we'll be able to develop a vaccine within the year, starting with the outbreak of this in February or March, and the hope or expectation that we would have one by the end of the year is very aggressive. It looks like we may be on time with some of those 7 that I mentioned to have a vaccine by the end of the year, certainly the first part of the next year. But I think we have to keep in mind that it's a very accelerated process. With that comes a few points that are worth considering, and that is whether or not folks are willing to accept a vaccination that has been fast-tracked, if you will, or that is new. So an important point about vaccines, and we're going to talk a little bit more about this in a moment with regards to herd immunity, is that in order for them to help us prevent the spread of disease, it's estimated, and again, this is an estimate, that somewhere between 70 and 80% of the population either needs to be vaccinated or be immune to the disease to help decrease the spread. And if we compare that to the average vaccination rates for, say, seasonal flu, that would be a pretty aggressive goal for us to consider. So I think most folks put the annual flu vaccination rate at somewhere around 50 to 60%. And so we're saying that we would have to do better than that in order to achieve meaningful levels of immunity to prevent the spread of COVID-19. So the last point on the slide we'll make, there's been a little bit of chatter in the news lately over the last few weeks that Russia and China have vaccines that are available or that they're pushing ahead with. But it's important to note that that they may have either abbreviated or skipped some of the steps that we normally would attribute to a vaccine development here in the States, principally either skipping or rushing through that phase 3 trial. So more to come yet on vaccines and the availability of it, but certainly I would not be concerned or upset that Russia or China has something that we don't, because I'm really a little bit more concerned that they may be rushing the process more than need be based on that information. So next slide, herd immunity. A little bit of explanation about this slide. A couple points to make. First of all, in the bottom left, shout out to my daughter, who's a senior in college at Bucknell University. So when I was thinking about how to illustrate or document herd immunity, a herd of buffalo came to mind, or in her case, the Bucknell bison. So that's the Bucknell reference down there to her senior year in college. But the concept of herd immunity is that if we can you can achieve herd immunity through one of 2 ways. You can either vaccinate enough of the population, like we talked about a moment ago, that limits the spread of the disease, or you can have enough people in the population that have exposure to the disease that others are protected. So if you could envision that all the rest of those buffalo or bison in this picture had SARS-CoV-2, except the one little baby buffalo there in the front, if they've all been exposed to it previously and have immunity to it, then the likelihood or chance that they're going to pass it to that baby bison is very, very low. So that's where we get the concept of herd immunity. The unfortunate news, if you will, about herd immunity is that high number that it takes in order for it to be effective. So if we think back to some of our earlier slides, the estimates that I would have to put out as far as how much coronavirus or COVID-19 do we have in our community Our asymptomatic folks that we test, it's less than 1%. And even folks that are sick or that we really suspect having it, we're only seeing around 4 to 5%. So in order to have effective herd immunity that limits the spread of it, you would have to have a vast preponderance of the population that have been exposed to it and develop antibodies to it. And we're really not anywhere close to that. So if we want to think about the end game or the goal of where we're headed with this, I think we have to focus a little bit more on vaccines with regards to limiting the spread of it, because we're certainly a long, long way away from herd immunity. So next slide. So this brings me to the other thing that certainly got a lot of publicity and press, and people have a lot of strong feelings about, and that's social restrictions or social distancing. So if you look at the examples there across the bottom, those are sort of two ends of the spectrum. The first two little pictures, we see a restaurant or a bar scene, a lot of folks in there having a good time, enjoying themselves. In this particular picture, nobody has on masks. That's just because that's the picture I pulled. It's not a defining characteristic of that interaction, but nevertheless, in a crowded place and nobody with masks on, you are putting yourself at risk for exposure. Versus the next picture, the two folks watching the sunset there, having a drink on the beach. Looks like they're a couple, maybe a husband and wife or boyfriend and girlfriend, and certainly they're having a good time and enjoying the evening, but they're doing it in what you could argue is a socially responsible way. Same thing in the other two pictures. The other two pictures is the third picture, if you will. That's a large worship service at an indoor arena with 15 or 20,000 people present, versus a comparison there of an outdoor worship venue. Folks spread apart a little bit, and certainly outdoors and where they can keep a respectable distance. So yes, we're beginning to gather a little bit more. We go back and forth with restaurants and official capacities and lots of discussions about what are safe activities and fall sports and the like. And my encouragement to folks is really to consider your what's best for you. Consider whether or not you're somebody that has other health problems that's at high risk for having complications, were you to be infected with coronavirus. So what we tend to see, the folks that fall into that high risk group are folks that are elderly, certainly over age 60, folks with other health problems such as high blood pressure, heart disease, diabetes, and pulmonary disease, including asthma. So if you're in those high risk groups, you may want to consider about the activities that you do. So if you're in those high risk groups, then you probably do want to have a thoughtful conversation with friends and family about being in certain social situations. Are we going to attend church in person or through Zoom and the like? Are we going to go to social functions like weddings or football games and put ourselves in high risk situations? Or are we going to do like in these other two slides? Are we going to choose carefully and consider how we interact on a social basis? So, last slide. Really, this kind of summarizes our recommendations. So these are very simple things. I've kind of ended most of my talks on all these simple recommendations, and despite the evidence that we have to this point, and despite all we've seen and learned, we're really still back at the same things, which is the encouragement to wash our hands. Hand washing is so important. And even outside of coronavirus or COVID-19, as we begin to enter the flu season and the cold season, um, being considerate, washing your hands, particularly if you're in public places, using hand sanitizer. We can't emphasize that enough. I really like the guy here in the middle with his coffee filter. Again, maybe that's my different sense of humor, but this slide really was kind of funny to me. But wearing our masks. So I know it's a pain. I know it's tough when you pull up to somewhere and you've got to run in just to grab one thing, and you get halfway to the door and you're like, oh, I forgot my mask. I got to run back to the car. But as that other favorite slide of mine demonstrated, if you happen to be a carrier of COVID and you're wearing your mask, your chance of you spreading the virus to somebody else drops dramatically. So encourage folks to wear your mask whenever you can. And then the last recommendation is again with regards to social distancing. And I'm not here today to tell you you should or shouldn't go to social functions or be in social situations, or really to say that those things are good or bad. But I think each individual person has to decide for themselves um, what level of risk is appropriate for them, and what risks they're willing to take for them and their family. So I'll close at that point. Happy to take any questions at this time.
I have a quick question. With school starting back, many folks are wondering about their children going back to school and ways to teach their children better ways to handle this with mask and distancing and things like that.
Yeah, so that's a tough one. I've had some conversations with different folks at the schools and helping them kind of think through some of their processes and how they approach it. And obviously, our approach with kindergartners and first graders is very different than 12th graders, seniors in high school. So I think, as always, unfortunately, it's leading by example. So making these three things: hand hygiene, masking, social distancing, making them part of your daily routine demonstrates that it's appropriate. I think it also, to some degree, helps alleviate some of their fears. So just to pick on masking, for instance, if masking hasn't been part of your daily routine, but then now all of a sudden the child's going to have to wear a mask at school, it's going to be a little bit scary. But I've been impressed. My youngest is 10 years old, and I oftentimes don't have to remind him now when we get out of the car to mask up. He'll either have brought a mask with him or had one stashed in the back seat. He'll grab it, and I'll look around, and he's already got his mask on, and we're headed up to the door at the grocery store. So I think as much as you can, incorporating these things into how you do life on a regular basis is important. I know the schools have spent an exhaustive amount of time in being thoughtful about how they approach this. And the hard part, again, is there's no right answer for each age group, and there's not even a right answer for each school, because it depends on the population of kids that they have. It depends on the number of kids that are going to be in online versus in-person instruction. But I know they've put a lot of effort, and I applaud them for the effort that they've put into figuring out how to do this and do this safely. And I know from talking with them that they've really invested a lot of time in how to clean their schools and provide as safe an environment as possible. So, the last point I'll make, I guess, and this is hard because, we like to grumble and we like to complain, but to the extent that we can be supportive of our educators and be supportive of our school leaders and the plans that they have put in place, and try not to downplay the importance of it, I think that'll go a long way towards keeping our kids safe, and doing so in an environment that's not stressful to them. We certainly don't want them to be scared of school or scared of attending. And I think we have to be considerate of how we speak of it in front of them and with them as we incorporate these aspects into our daily life. So I see a question on here. How has working inside the hospital during the pandemic been for us and our staff? Are we happy with the way we've handled ourselves in the situation throughout? And the very short but emphatic answer is I am very happy with how we've handled it. Our staff here have been absolutely tremendous. They have sacrificed a lot, frankly, to work through this and work here in the COVID environment. But I would be remiss too if I didn't thank the local community. So the outpouring of support from the local community early on and still today, the shows of support and thank you and bringing food and meals and signs, it really meant a lot to the folks here, and our folks really rallied to the occasion. So that's been the great news to this point. But the point I would still make, and that I made early on, is that it looks like we're going to be in this for some time now, in this for the long haul. So continue when you can to be thankful to those that work in the hospital, both nurses and physicians, but really all members of our team have had to go above and beyond to be able to handle this new work environment that we have here. So big thanks to our staff and a big thanks to the community for the support. Oh, looks like one may have popped up.
If there are no
here.
other questions,
Yep.
we thank you, Dr. Housman, for a very informative update. We appreciate you sharing your knowledge and insight. I know you're a busy man. We thank you for your time today and very, very interesting presentation today. And everyone who joined us today, we thank you for being part of the library's virtual programming. And this program will be posted on YouTube, and we hope you'll share it with your family and friends. Plan to attend another library virtual grant. We're going to stay around for just a couple of moments if anybody has any last minute questions for Dr. Housman. And again, we thank you so much for being part of the library's virtual.
Yes, thanks again for having me.